Good afternoon and good evening, everyone. Thank you for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Professor Yap Boom, the Deputy Incident Manager for the Incident Management Support Team based out of DRC. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you so much, Margaret. Good morning, good afternoon, good evening, based on where you are. It's been a very critical week in the area of pandemic response and preparedness, as I will be able to give you some highlight, but also a week where our leaders at the EU also were meeting to discuss how the continent is actually impacting the global health. But also a week where we met as IMST to see how we can, on one hand, reach the last mile on the fight against Mpox, in the other hand, accelerate the response to cholera. As you will see, we can still see the case increasing as the death as well. So a critical information that we'll share today, and then I'm willing to start as when you are ready, Director Margaret. Next slide. So this week, as mentioned, the week has not ended, but it's been full of different engagement. The first one, and which was the meeting between African Union, European Union Summit with the head of state, minister, and also partners that happened in Luanda, Angola, Monday and Tuesday. So those discussions were critical, especially at the time where we've been appreciating the decreasing of ODA, we've also appreciating the change, the new vision of Africa CDC. So it was an opportunity to highlight the importance of strong partnership and coordinated action to advance Africa health, security, and sovereignty agenda. So during those different conversation, engagement, our Director General, Dr. Kaseya, emphasized that the progress we are driving is only possible when we align around clear priorities, deliver at scale, and keep Africa people at the center of our work. Next slide. During the same week, moving to that global gathering, but now focusing more in Johannesburg on the NCDs, it was actually the opportunity to also reemphasize the role of Africa CDC, which is not only on the epidemic, but also on addressing the growing burden of cervical cancer, hypertension, diabetes, all those non-communicable diseases, which are moving alongside of the infectious disease. So which is ensuring that as a continental entity, we really need to be on all those different fronts. And that's led to the discussion which underscored that strengthening health security and health sovereignty is critical. It's really essential to ensure that every woman, every child, and every community has access to the care they need. And those are not only words, they are actually critical action that need to be implemented, and Africa CDC is committed with the different partners, including Aspen and others, to move that agenda forward. Next slide. Last week, we were announcing already that the Pandemic Fund has announced that the third call for proposal and Africa CDC were awarded, though the amount was not known. But today, we really want to congratulate the 7 African countries, Senegal, Cameroon, South Sudan, Angola, Zimbabwe, Somalia, and Malawi for their successful allocation under the Pandemic Fund third call for proposal. And it's important, it's really critical to emphasize that this achievement firmly ensure that the country are in the driver's seat. You remember, the country leads, the regional coordinates, and the global support. So this is really the support, the financial support, the technical support that the country will receive to ensure that they define their own priorities, they mobilize substantial domestic and international resources, alongside the fund support that they are going to receive. So we believe that this will be a transformative element for those different countries and the countries around, and us as well as Africa CDC. We have also received some substantial funding that will also allow us to improve the efficiency and the diversity of the support that we can bring to our member state. Next slide. Now, still in the area of response to pandemic, but also making the link with the NCDs, we believe that the community is at the center of everything. That's why this article, Accelerating Community Healthcare Workers Program in Africa, published in BMJ Journal, highlights that they are essential, critical for Africa health security and primary healthcare. The target is to reach the 2 million community healthcare workers needed to deliver primary healthcare and detect outbreaks early. As per today, we are 1 million, so we are halfway. So to move toward that, we need to accelerate and also harmonize those programs so that we move in alignment to the Lusaka agenda and, of course, the new vision of Africa health security and sovereignty. So we want really to use that approach to limit the fragmented and the underfunded and poorly coordinated community healthcare worker effort that we've been seeing in the continent. By having that harmonization, we will accelerate reaching the 2 million CW in countries, which will have an impact on one side on how we control, detect early the outbreak, but also on how we manage NCDs at the community level. Next slide. Now, coming back to the outbreaks, to our public health events, we still have Mpox, which is leading in the number of member states, cholera in the number of cases both suspected and confirmed, but also in the number of deaths that we've been seeing across the continent, with 7,134 deaths that has been reported this year. We have measles that is also continuing to increase, as well as dengue, while Lassa fever remain limited in the 4 member states. Next slide. Namibia, which we were emphasizing some few weeks ago, for the discharge of the last Mpox patient, have now reported a fatal case of Crimean Congo hemorrhagic fever in Comas region, and the patient was admitted at the hospital of Windhoek, which is the capital city, on the 18th November 2025 and died on the 19th November 2025. So the lab confirmed the CCHF virus. It's important to know that this is not the first time that this disease is appearing in Namibia. It has been around since the 18th, and there are some sporadic cases that are coming once in a while. So the lab's infrastructure is present for the detection, and the country has initiated the contact tracing, the surveillance, and other intervention to contain the virus, and is urging the public not to panic. This is very critical to ensure that the community appreciate that all efforts are being put in place to limit the spread of this disease. Next slide. Marburg virus disease in Ethiopia. As you can see, to date, we have 12 confirmed cases, 7 deaths with a case fatality ratio of 58.3. And still the affected zone of Jinka remain the only one that has been affected. Now we have 2 patients who have recovered. We have 3 patients on treatment as we do speak now. So the IMS has been activated, and then there have been some meetings with the Ministry of Health and the different partners. A response plan has been presented, and now we are expecting the government, the leadership of the Ministry of Health, to assign how the different partners will be able to support all the efforts that are already implemented by the countries. South Sudan on the side has also activated the EOC. They've been receiving some support in terms of laboratory, in terms of training, or some of them will be implemented in the few days or weeks. Next slide. The Ebola virus disease in DRC, we are really counting down, and the 1st of December, the declaration of the end of the outbreak will be celebrated in Kinshasa, DRC, and highlighting once again the leadership, but more especially the maturity of the National Health Public Health Institute that has been leading the response to this outbreak with the support of all the different partners. So this is a very good example. And then we look forward to the 1st of December, where we can celebrate, but also listen, read, write all the lessons learned so that we can use them in Ethiopia, where they are dealing currently with MVD, but many other countries, as we know that the preparedness is to those outbreak is quite critical based on the evidence that we keep on gathering as we move and respond to outbreaks. Next slide. In Senegal, the Rift Valley fever is keep on decreasing. Last week we had 43 cases. This week we have 31. In total, we've been confirming 500 cases with 31 deaths, with a case fatality ratio of 6.2. We've also recorded a death, which with a case fatality rate of 0.5%. A death, which with a case fatality rate of 0.5% on the confirmed case and 1% on the suspected case. As we do speak now, and you will see, Sierra Leone has last confirmed case 133 days. That was in the site of Karene, and in Bombali 31 days. So the country consider the lowest, which is 31 days, and they are also moving on the countdown. Next slide. At the continental level, as you see again, and we have been talking about the Liberia, where we see the cases that are increasing. Lots of effort are being implemented in the country. They will also receive, as we also mentioned, some support, multidisciplinary support that will come together with the vaccine that will help them to control the outbreak in the most critical environment. In Central African Republic, though the cases are small in numbers, we can see that increase that is still continuing, especially in places where they have not been used to have the Mpox case. Nigeria, there is a slight increase, but most of the number are pretty much stable. And then we see some decline in Kenya, Ghana, where we were actually looking last week with some few increase. Burundi also is continuing to decrease, which is quite reconforting, knowing that they are dealing with other outbreaks. Next slide. Mali, on the 21st of November, the Director General of Public Health put a public notice signaling a confirmed case of Mpox in Kangaba Health Area, Mali Health Zone of Kulikoro, in the region of Mali. It's important to highlight that that area is quite close to Guinea, and those are areas where there are important mobility between the different populations. So far, there is one suspected case, one confirmed case. All the suspect has been tested. The testing rate is therefore 100%. So the instruction by the ministry has been to activate an initial response measure, which include the surveillance, the contact tracing, the laboratory, and the testing of suspected. And you remember the key driver to successful response, as we've seen in Namibia recently, the high leadership at the ministerial level, the surveillance at the community level, but also the management of data. Next slide. In Sierra Leone, as we are doing for Ebola in DRC, we are also in the countdown. As mentioned, we have Bombali, which actually is not 28, which already has last 31 days without any case, which made the country at that level. So we are following up, and then we keep our finger crossed that there will be no case before the countdown, making Sierra Leone one of the first countries declaring a 0 case after a peak that went as up as more than 700 cases within the same week. Next slide. In Liberia, a country that we've been mentioning where the challenges are quite important, especially in surveillance, so community-based surveillance. As you see, once again, now that we are all becoming expert in epidemiology, we can see that test positivity rate is quite high, 81%, highlighting that the people who are positive are coming late, and the real case might be in the community. That's why a team of of IMST, including surveillance, vaccination, RCC for the communication, will be supporting together with the colleagues from Sierra Leone so that they can go and use the lesson learned from the neighboring country for the IMST and focus on those hotspots, Montserrado, Nimba, and so that's actually represent more than 66% of the confirmed case. Next slide. In Kenya, we see a small decrease in the number of cases over last week from 44 to 31, but we still have Mombasa, Busia, Nairobi that account for almost 70% of the total confirmed case. So this is really the place where the action needs to happen. They've been receiving 10,000 doses of vaccine that has been used a while ago, and then now they're expecting 20,000 doses of vaccine. So now also in Kenya, the team will go and work together hand in hand to ensure that in those hotspots, there is that multi-sectorial response, integrated response using the vaccination, the surveillance to limit the spread of the disease. As per now, majority of cases, 72%, receive care under the home isolation, which of course is a challenge as we've been seeing in other countries. Sierra Leone that we've highlighted decided to move back to facility-based isolation to provide quality care to patients at the same time stopping the spread of the disease. So that is something that the team will also go and discuss with Kenya what is needed to actually reduce the number of people, proportion of people being taken care at home to move to the facility care. Next slide. Now, in terms of vaccination, we keep on moving toward the 5 million doses of vaccine delivered in the different countries. Also moving toward 2 million people who have been vaccinated with at least one dose of vaccine. So Mozambique has started the rollout of, so this is one of the last countries that have received the vaccine and then who are going to provide it to the population. Next slide. Now, in terms of, still in terms of vaccination, we've mentioned that the high burden countries, the high spot country, let me put it that way, Kenya, Liberia will be receiving on the 3rd of December, 20,000 doses of vaccine for Kenya, and then on the 10th, 20,000 as well for Liberia. So those vaccines will also arrive when the team will be on the ground to really support and ensure that the surveillance, the vaccination, the RCCC all goes together and ensure that we can really eat the end of the Mpox in those countries. By the end, we mean going below the threshold. Now, different countries, Sierra Leone, Uganda, and so on, are moving toward the fractional dose. We've been talking about it a while ago, and now the Sierra Leone will be receiving 300,036 devices for this to happen. And Uganda have not made any request, but they will be implementing once they get the approval for the NITAG and the other authorities. Next slide. Now, going back to our biggest challenge that I mentioned, cholera. And once again, I mentioned that we want to push Mpox the last mile, while we want to accelerate the coordination of the response to cholera in the continent. The team within the IMST, which include the GTFCC, all the different partners, WHO, UNICEF, and all of them who have been working in cholera before the IMST have been joining to accelerate with what we call the Instant Action Plan so that they can move starting from next week in the high spot, the high burden countries, so that they implement the lesson learned. We've learned a lot from evidence from the research on which vaccine works, how does it work, which wash, and what we need in terms of strong infrastructure, because we've learned also with all those evidence that the medical response is definitely not sufficient. So we have 5 member states, South Sudan, Sudan, DRC, Angola, and Nigeria, that contribute to 87.8% of all cholera cases reported in 2025. So this is really the key country. But however, you will see that there are other countries where we've seen the number going up. Next slide. As you can see here, we have the surging outbreak. Those are the countries like Kenya, Angola, Mozambique, and Burundi that continue to show major increase in the last 6 weeks. Now we have Angola on another side, which the resurgence is keep on growing, as we will be seeing soon, while we were having the first wave that really went down as expected, but now, which is also challenging. This second wave, next slide, is also highlighting the challenge of moving the response to those outbreaks based on the evidence that we gather as we get to know more about those diseases. In Kenya, we are supporting the country to respond to those that second wave. This morning we were having the colleagues from Kenya also reporting some of the challenge during our weekly delivery. So in terms of intervention, the critical one are really the training of clinician and cholera management, distribution of wash supply. Those are measures put in place to limit, to control. But definitely we know that until the access to clear and potable water is not available for the large majority of the population, we'll still be having those challenges. The case fatality rate here is 3.92%, with 26 deaths out of 656 cases. Next slide. In Angola that I've mentioned, Angola is one of the countries that really challenge us on the way we respond to those outbreaks, on the critical need that has been mentioned to have the multi-sectorial approach, but also on the critical need of using evidence. You see, we've been having the first wave. We have vaccine that has been used to protect population. It went down, now it's going up again. So the key question that we are asking, and tomorrow we'll have some colleagues that have been working on the vaccine effectiveness of cholera vaccine, is the approach that we are using with one dose of vaccine being used to control an outbreak. Is it actually efficient? Is it working that well? Should we mobilize more doses of vaccine so that we have the proper 2 doses to control the outbreak, though we know that there have been some limitation on the dose available? But also discussing with the different partners, we are also aware now that the production of the vaccine is increasing. So those evidence might allow us to adjust the response and then say maybe we should go back to 2 doses of vaccine to ensure that we have a long-lasting protection, especially in those places where the challenge of availability of clean water is not yet there. Because as you can see, roughly 44% of Angola's population lack access to safe drinking water, and only about 55% have adequate sanitation. So until we decrease actually those numbers or increase the number of people having access, we won't be able to sustainably stop the outbreak of cholera in Angola and many other countries. Next slide. In Burundi, gladly, we appreciate the reduction in the number of cases. This is also an evidence of the multi-sectorial approach that has been implemented. Through the leadership of the First Lady, they have been implementing some activity, gathering different partners for the public sector, for the private sector, to ensure that they implement the sanitization, but also build some pothole in places where the access to clean water were not available. So merging the medical countermeasure, but also this community engagement with the public and private partnership is producing some very good results. And as you can see, the case fatality ratio is quite low also, with 0.4%, while we have been seeing in some places where we were more than 7% at some point. But still, the access to water is not for all the population, which remain a challenge. With the fragile water infrastructure and the onset of rainy season, as you've been seeing in many of our countries, it's upcoming as we are in the months of November, moving to the months of December. Next slide. In summary, Ebola, the 1st of December, the declaration of the end of the outbreak will be done in Kinshasa. All the lessons learned will be taken and will support many other countries who are fighting against MVD, which is Ethiopia, for example, to see what has been implemented in Bulape that can also support the response. As Mpox is concerned, we continue to see the decline, and then we have some few countries, Liberia, Guinea, Ghana, where the transmission persists, and we have Mali that has reported the first case since the beginning of this outbreak of 2025. Cholera, the major outbreak, are surging in Kenya, Angola, Mozambique, and high transmission persists in DRC, but also Nigeria and many other countries. So what we are doing as the IMSC platform is really to push the last mile on the side of Mpox, but the coordinated approach with all the different and existing partners on cholera will go in the most affected countries and provide technical support, some commodities, so that we can see an impact before we reach the end of the year. Because we all know the end of the year is a time where there is a lot of mixing of population. So we really want to ensure that before we reach there, the vaccine that will be received in Liberia, in Kenya, are properly used, while the medical countermeasure, the surveillance, and orders against cholera are implemented in the high burden countries. So this is what we wanted to share with you today. And of course, we'll be very happy to answer the question that you will have for us. Thank you. Over to you, Director Margaret.
Thank you, Prof. Let's take the first two questions. We have one here in regards to the Marburg outbreak in Ethiopia. Has South Sudan taken any steps in safeguarding its borders? With Jinka's proximity to the borders of South Sudan and Kenya, what specific cross-border surveillance mechanisms have been activated? And then the second one here is on the anticipated travel advisories requirement for intra-Ethiopia movement between affected areas like Jinka and major hubs like Addis. And how should businesses adjust employee relocation policies accordingly? Back to you, Prof.
Okay, thank you so much for the question. I will start, and Dr. Mercy will emphasize on the cross-border activity that are happening in Sudan. So to talk about Sudan, but also Kenya, those are the two neighboring countries, and to some extent even Somalia. What we did is to engage at the level of the Ministry of Health to provide, first of all, the information of what was happening, but also to support them and assisting that rapid risk assessment that was done together with the colleague of Africa CDC and WHO. And this has highlighted some few gaps in terms of laboratory, in terms of trainings, in terms of surveillance that is being provided to South Sudan. And this is after they've activated their EOC by themselves, which is also a good sign of maturity of the South Sudan on responding to those outbreaks. So maybe Dr. Mercy, specifically on the cross-border surveillance, maybe you can say some few words on that. Over to you, Dr. Mercy.
Thank you so much, Dr. Prof. And I think that's a very important question and concern. The issue around cross-border in the Eastern region goes beyond just the main public health sector, but also emphasizes the need for a whole of government as well as multi-sectorial coordination mechanisms across the border to really facilitate the different issues that are rising within Sudan. And I'm saying this because if you look at the situation, it has some humanitarian be tagged to it, security issues, which definitely goes beyond just the mainstream public health. And that is why it's beyond just the Africa CDC acting, but again, it's been activated at the highest level of governance of the African Union, and we have in the AUC actually championing this space in collaboration with Africa CDC to ensure that we have a multi-sectorial and also look at the humanitarian aspect. In terms of the coordination within the region, we also have the Regional Collaborating Center, as well as some community of practices that practice groups that already exist within the Eastern region. And the RECs, also in coordination with the RECs, we are mobilizing and convening the countries to come share experience on how some of these issues have been tackled in the past, as well as share information on how some of these outbreaks can be better measured. So they can be better controlled, So the countries are actually having routine meetings with Sudan, have been part of that expert coordination group where issues around epidemics are being shared, as well as lessons are being learned, and peer-to-peer support ongoing within the region. Over.
Thank you, Dr. Mercy. Now, on the question of the travel, the businesses, and so on, when you respond to those kind of outbreaks, you really deal with a dilemma. One, you really want to stop the spread of the disease. And two, you want to avoid panic within the population, and then you want to limit the socio-economic impact within the country and within the region. So what has happened is that some non-essential, non-critical event, there were some conference, there are also some tourist activity that were planned to happen in Tinka. And you all know now that Tinka is a very, very touristic area. So those non-essential gathering has been cancelled or postponed. This is on the side of ensuring that they limit the spread of the disease within the country, but at the same time, the critical activity has been maintained or should be maintained to ensure that the life continue while all the other activities are implemented. Because the most critical thing in the response is not to stop the people, but also to ensure that the surveillance is well implemented at the level of the community, that the laboratory is functioning, and that the people have access to treatment and other medical countermeasures, which currently the country is pushing to implement.
Let's cross over to the floor. Now we have Sarah Javing from DVEX. Sarah, you have the floor.
Dr. Kaseya had posted this week a post about meeting with the State Department about the bilateral health agreements. I'm wondering if you can talk about kind of what the nature of these discussions were and kind of what Africa CDC has learned about these ongoing negotiations around the bilateral agreements and anything else in regards to that meeting.
Thank you. Let's take the next question before Prof comes in. We have Kemo Cham from Mano Reporters. Kemo, you have the floor.
Hello there. Thank you. I just wanted some explanation. Within the last year or more, we have seen some kind of pattern that suggests that we are almost at risk of one outbreak or the other. It's like we're just waiting for something to trigger it. I'm speaking in the context of the Rift Valley fever in Senegal. Two questions. One, I would like you, Professor, to speak specifically about what Gambia, for example, and Guinea are doing, even though we heard that the cases are decreasing, but what are these countries doing to prevent this from crossing over? Guinea is of particular interest to us, Sierra Leone, given our proximity. That's one. Two, with that in mind, the kind of pattern that we have seen, recently there was a study here that indicated that diseases, viruses that we thought were not here, were in other parts of Africa. Dengue, for example, they found that it was in many, many people in Sierra Leone. So in that kind of situation, what does this call for? In the Africa CDC's public health response, what should African countries do rather than us just waiting until something comes up and then we spring and start putting things in place, and we often get it wrong? Over.
Back to you, Prof.
Thank you. Thank you so much, Sarah and Kemo. Thank you, Kemo, for the question, but also for spreading the news. We've been also following you on how you communicate following these briefings. So, Sarah, as we did mention, we have those 16 countries that are the first batch of bilateral engagement of the US government. Before those meetings started, Dr. Kaseya conveyed all the Ministry of Health of those in the position to support. So once that will happen, we'll definitely give, especially in Guinea, which is of your interest. But I will start with the second question, where you were talking about dengue. What we've been seeing that the country that were not reporting some of those diseases are now reporting them. But that does not mean that they did not have them. Maybe they were not looking for those viral infection and others. So first of all, you need to appreciate that following the COVID-19, lots of effort has been implemented in many countries to ensure that they have the laboratory capacity, the genomic sequencing, and all those capacity that ensure that those countries are in a position to properly detect, because you won't find what you are not looking for. That's the first thing. The second thing now, when you have the lab capacity, you implement the surveillance system. Many countries have been trained on event-based surveillance. So all those activities, the laboratory, the surveillance, and now also strengthening the capacity of country in terms of EOC, emergency operating center, as has been happening. I think Africa CDC has supported more than 28 of them. Now, all those infrastructure equip the country to follow up and detect some of those diseases that were not considered being happening on the environment. That's one. Now, on the second part also, we are all seeing how the climate is changing, is evolving in many of our settings. And that leads to the apparition of some new disease, or actually to limit the frequency of those outbreaks. We were talking about Namibia. They've been having the criminal hemorrhagic fever since 80, but now you might see that some of those occurrences will keep on reducing, and we will be able to have more and more. Same thing is happening from Ebola virus disease. So one, the country has better capacity to detect all those, and two, we are also facing how the climate is also affecting the fact that those vector-borne disease and others, those zoonoses, actually, we are getting closer to the animal, and therefore the probability of exposure is higher. So Dr. Messi, maybe you can come on the question of the Rift Valley fever and the surveillance among the different countries.
Yeah, thank you so much. So for us at Africa CDC, what we've seen is a growing it's an increase in the vector-borne diseases. And as you know, most of the Aedes is distributed almost across every country in Africa. So even those that have not reported a case, some studies that have been conducted looking at, seroconversion of some of these diseases, we've seen that the proportion, the prevalence in most countries are showing that most people have been exposed. So in countries where we don't have an active human case, it just needs an introduction of an active case for that to pick up, and maybe an outbreak could be introduced. So we have the vector. That is a fact, and we all have to agree that these vectors are the main drivers to the spread of the disease. The second thing that we definitely are aware of, and we're taking very intentional steps towards addressing, is the weak coordination, weak multi-sectoral coordination in countries. And one of the things that Africa CDC has done is we've developed a One Health framework at the level of the AU, and this framework is being guided by the different sectors. We have the Africa CDC, we also have the AU-IBA that is championing the animal space to ensure that we really support countries in establishing the multi-sectorial coordination mechanisms in member states. And this would ensure that we have collaborative surveillance in place where these different sectors are able to share information. For instance, Rift Valley fever that has different phases of the outbreak, where we have the episodes and we have the zoonosis phase. We also have the phase within the human and all that. We are able to detect in these different populations and share information accordingly. The third thing that also we are supporting countries to be able to put in place is building robust diagnostics in countries so that they are able to conduct differential diagnosis. Some countries are having some of these diseases, but they are not just able to detect, because I remember there was a country that was reporting, that was misdiagnosing a dengue for malaria until the cases were not responding to treatment, and before they went in for differential diagnosis and found out that that was malaria, that was dengue, sorry. So we are seeing this in so many countries, and one of the things that we're really supporting is the fact that we provide diagnostics capacity in these countries to be able to detect and report. And until you know what you're dealing with, definitely you cannot put in robust preventive and response measures to control. So those are some of the things that we're doing. And for the cross-border surveillance, we are also supporting routine cross-border meetings, cross-border establishment of cross-border coordination mechanisms, where countries can also share information and and ensure that they also learn from each other. They agree on indicators, specific indicators that they can share across board that can also help to understand the dynamics of transmission and all that. For instance, if there is a mutation, then picked in country B, the country should be able to share with country A to understand that this is what the novel information about this disease looks like. So those are some of the approaches that we are putting in place, and we are hoping that these would definitely support countries to be able to mount up robust measures to respond. In addition to the climate change agenda that the Africa CDC is also championing, because like Prof mentioned, these vector-borne diseases are also being driven by climate change, and these are some of the things that we need to really take into consideration. Over.
Yeah, thank you, Dr. Murthy, and also to emphasize that next week on the side of the ICASA HIV conference, there will be a side event organized by the IMST to emphasize the importance of that cross-border surveillance, the critical of sharing data, sharing sample, but also the critical of having a unified database using the DHIS tracker, which we are also using as a legacy from the Mpox. Over to you, Director Margaret.
Let's take the next two questions. We have Paul from the Lancet. Paul, you have the floor.
Thank you very much. Can you hear me?
Yes, we can hear you. Go ahead.
Yes, thank you very much. So I want to ask a question that takes what my colleague from DevX asked, which is these meetings have been held quite a number of days now. Do we have any indication regarding even any insights you can give us regarding how the US government's current approach in Africa is going to look like? And I also want to know what Africa CDC's positioning in the new America First approach of the US government is going to be. So what is Africa CDC's vision for its involvement in the new global public health order of the US government going to look like? I also have a question. With the Ebola outbreak in DRC on its way to being declared over, we see this as probably the extension of the role of the IMST beyond Mpox itself. So what insights can you share from this practical experience of integrating a non-Mpox response into what IMST has been structured to do, and how you were able to engage the government of the country to take more proactive role to justify the mission of localizing Africa's response and putting African governments in charge of their public health? Thank you very much.
Thank you. Back to you, Prof, as those are loaded questions.
They are actually, and that's what we expect from Paul and all the journalists. No, thank you so much. Now, to go back to those meetings, you all know those are political meetings in some way, very strategic, and most of the time you don't have the disclosure of those meetings until there is a common ground at the country level, but also a common understanding at the continental, which definitely in a very transparent way, Paul, I can assure you that will provide you a feedback. But what is critical is that all those conversations and also the US first strategy, it's also coming at a time where Africa CDC has also relaunched its new vision of Africa health, security, and sovereignty. And being the member state organization, we know that we want to be aligned with the Lusaka agenda. We also know that we have key pillars we are emphasizing. So after all those visits, we'll sit down in a very open way and see how the American perspective and the African perspective, where do we overlap? And definitely we will, because we are interdependent. At the Africa first, the America first, sorry, it's also relying on the capacity of the African continent to protect itself. It also emphasized or strengthened the issue of domestic financing, because one of the ideas is that at some point the support of US will decrease. I think there are many points where we are aligned. So after the different visits, we'll sit down and see where we overlap And where we don't, then we support our member state on the way they will be continuing the negotiation. But promise, Paul, you will have all the information once they will be available. Now, this question on Ebola, it's a very good and interesting one. You know, IMST was an innovation on how we can work together to have more efficiency and so on with all those different partners. Now, it has worked for Mpox, though Mpox is not over. We are going toward it. It has included cholera because of the call of action for the different presidents. So now the question is, how can we continue the integration? And this integration that you mentioned on Ebola, it's happening at different levels. The first level, MST is a tool for response. So now the question is, how the way it's working with other partners, why don't we also integrate the preparedness so that we have countries that are supported by the same platform, whether they are currently in the outbreak, and this goes back to the different question that has been asked previously by some of your colleagues. How do we support the country before the outbreak is coming on the side? So we should be able to have that preparedness part. And now, are we going to stop as cholera, Mpox, Ebola at some point, maybe MVD? That's also the thinking process that we are going through. But it will be a natural process which will be discussed with all the different partners, with the member state, and see what are the different adjustments that we need to implement. Because normally IMST, it's a defined platform. It's implement to respond to an outbreak for a certain period of time. Now we have that protracted outbreak. And then we have this platform, which is flexible. So we need to find out, maybe it will not be the name IMST, maybe it will be something else, but definitely we will keep the same model to have more integration, preparedness, response, and most likely other disease.
Let's take the next two questions. We have Esther Nakazi, a health and science journalist from Uganda. Esther, you have the floor.
Thank you, Margaret, and thank you, Professor. My question is about the cholera outbreak that you talked about, Professor. You said you're reviewing the opinion, you're reviewing the idea of giving 2 doses per person to the cholera for cholera for prevention. And I'm wondering, do you have these doses available? And besides Angola, where you proposed this is going to be done, which other country are you going to do this? And yeah, thank you.
Thank you, Esther. Let's take the next one. We have Kumba from Gambia Daily. Kumba, you have the floor.
Good afternoon. Thank you, Madam Margaret, for the opportunity. Thank you, Dr. Yap, Professor Yap. I will go straight to I have 3 questions anyway. I don't know if time permits me. First, I will want to know about the African Health Security Agenda. Could you please provide an update on the progress of the African Health Security Agenda, particularly how Africa CDC is supporting countries to build resilient, self-reliant health systems? And my other question is, what concrete steps are taken to improve sustainable financing for public health initiatives, especially in areas like surveillance, vaccine manufacturing, and emergency preparedness? And also, Africa CDC has been discussing this, let's say, almost every press conferences regarding providing vaccine for Africa, providing that the COVID-19 experience of suspicions around vaccines, that Africa received 3rd-class vaccine and the like. So what progress has been made, or what is the stand or updates about Africa having its own vaccine? Thank you. Back to you.
Back to you, Prof.
Thank you so much, Esther and Kumba. So on the first question from Esther on the cholera outbreaks, we are a scientific organization, we want to believe, so that we rely on evidence. So when we look at a country like Angola, where the first wave was, the response was quite efficient, we see the peak going down, and then a few weeks later, we see a second peak. So the first thing we do, we turn ourselves to our scientists, our researchers, and trying to find what could explain what we are seeing. And that's why I mentioned that tomorrow we have the colleagues from the research pillar who will present us all the evidence around the OCV, the cholera vaccine effectiveness, so that we can make a decision based on the evidence. So, but what we are getting, even before the evidence that will be provided tomorrow, is that we all knew that one dose is definitely less efficient than 2 doses. But the evidence that we had at the time is that it was enough to control outbreaks. So which outbreaks, in which condition, this is also some of the evidence that we'll be discussing tomorrow. But surely the other advantage of the 2 doses is the duration. Instead of having a duration of the protection for a few months, then we are really talking about years, that one. Now, on the question of availability of the vaccine, this is a negotiation, and Gavi is also supporting the ICG to increase the production and the availability of those of vaccine. That's why we are quite confident in saying that on one side we have the evidence, on the second side we have the negotiation. Remember that Gavi, during the resource mobilization for the Cholera Continental Plan, they commit to support the 10 million doses of vaccine that will be necessary. So now if we go back to them and say that we need more, and they're also part of the IMST, so they are part of those conversations. So they are also being proactive and pushing to say that once the needs are increasing because we have the worst cholera situation in the world, so at this point we cannot do the same way we were dealing last year than this year. Triple the number of cases, number of deaths, we definitely need to do something, which include the vaccination. But also, let me take this advantage of emphasizing that vaccination is not all. We need to push more on the side of the infrastructure. That's why we get the support from our head of state. We are also having some of our researchers talking to us about new different way of intervention using antibiotics, for example. So all those evidence will support us on adjusting the way we are responding to the cholera. Now, on the question of the Africa Health Security Agenda from Kumba, you were asking what has been done in many things. So I will first say we supported the country to have more autonomy in how they manage, how they control those outbreaks. And I want to emphasize country leads, regional coordinate, and global support. So the lead is at the country level. That's why, as we do speak now, 29 countries in the continent have been receiving EOC equipment. So they have the Emergency Operating Center, which is well equipped, allowing them to properly control and monitor those different outbreaks. So we are not talking only about the infrastructure, we are also talking about the training of the people in those EOCs. Following that, the laboratory. We've been also saying that the decentralization of the laboratory has been one of the key legacy in many countries of the Mpox. The genomic were also started since the COVID. So we have countries that are more and more equipped in the detection, but also in the surveillance using the EOC, but also using all the different trainings that has been happening. And next week again, we'll bring together different countries to see how we can improve the continental unified database. So all those activity or action are being implemented so that we have more resilience. Now, last but not the least, at the National Public Health Institute, I think this is really the foundation of the autonomy of countries to control and to respond to those outbreaks. So seeing all those, we can really see and appreciate that a lot has been done. Still a lot needs to be done, but we can appreciate that now when you look at what happened in the DRC, when you see Sierra Leone, those outbreaks were managed by the NPHI, which has been there for 2 or 3 years. That's a good example of the maturity. On the issue of vaccine, specifically for Mpox, the tech transfer company has been identified a while ago. We've agreed on that. Now, the challenge was to have this process to mature. We need to have a proper demand to know how many doses, 3 to 4 million is the minimum dose that are needed to ensure that this movement can go up to the end. So for this to happen, is the demand present in the continent? Definitely. We have all those endemic countries, DRC, Cameroon, and so on, who are endemic for Mpox. Now, where we are moving is in the resource mobilization. How are we going to mobilize those domestic funding so that we can have the fund to allow the acquirement of those that will be transferred, and then we'll be seeing actually the local manufacturing happening. Over to you, Director Margaret.
Let's take the last question. We have Janice from Bloomberg. Janice, you have the floor.
Hi, good afternoon. Thank you for taking that. I just wanted to ask related to 2 questions that have already been asked, but maybe just phrased a bit differently. When we're talking about the America First strategy, that has largely played out as bilateral agreements between the US and specific countries. And obviously we saw at the beginning of the year how the US has pulled back or pulled away from the WHO. Now, the Africa CDC is obviously a very different body to the WHO, but it's not a specific country that they would potentially have a bilateral agreement with. And so maybe if I could phrase the question more, I know that the Africa CDC was in the US earlier this year and indicated at the time that they had felt talks were very productive. But we also know things change very rapidly in the current climate. And I was really just wondering where Africa CDC is finding itself in this new world of these increasingly bilateral talks between the US and specific countries.
Prof, back to you.
Yes, no, thank you. Thank you for asking it in a very different way. And really, I hope that I can bring as more clarity as I can. I think the first thing that is important to emphasize that Africa CDC, it's a regional entity, is from the member states. So there is no idea of Africa CDC replacing WHO and so on. We support our member state based on their needs and based on the opportunity that we see with them and for them. So the fact that the bilateral conversations are happening, it's good. You know, we are moving from a side where the US government was supporting countries through NGOs. This is no longer happening, which is already something quite important. Knowing that now it will be from country to countries. And us, as in being in a position to support our member state, we will ensure that all the benefits of our member state are very well considered and well taken. And on the side of US government, because we speak a lot about them, but it's much more than that, where we also build and strengthen the capacity of our countries. There will be, I think, 12 to 16 public health economists that will deploy in countries to support them on how they can have a conversation between the Ministry of Health and the Ministry of Finance so that they can push the agenda of domestic financing and all those others. So I think what's important and critical to have in mind is that our objective is Africa health, security, and sovereignty. And this will happen with all the different partners that will be aligned with what our member states are looking for, which is a healthier and safer continent.
Thank you, Prof. I'll now hand over the floor back to you for your closing remarks. We have come to the end of the briefing this week, and the floor is yours.
No, thank you so much, Meg. I can't say more thank you to all the journalists, really Janice, Kemo, Paul, and others. No, all those questions are critical for us. You sometimes take us back to something that we say 1 month, 2 months, 3 months before, and then we're happy because this is the accountability that we need, not for you, but for our communities and for our leaders. So we really thank you for that. We also appreciate all the colleagues that are working on those protracted outbreaks. You know, normally an outbreak will last 1 month, 2 months, as we are seeing with Ebola. Mpox has lasted more than a year. Korea has been there for a while, and the colleagues are there. For the IMST, the member state, and all the partners are really pushing. So we really want to appreciate once again all the effort. And I will end by thank you, the director of the Public Health Emergency Operating Center of Cameroon, who is hosting me today. As part of the joint external evaluation, this is a critical moment for a country. 7 years following the last one, the country is sitting down to assess how they prepare and respond to those outbreaks using a One Health approach with the supervision, the support of Africa CDC and WHO international experts. And at the time when the country also receiving the pandemic fund, they will have a clear roadmap. And then it's an opportunity not only for the country, but for the entire region. So with that, I wish you a very good day, a very good afternoon, and a very good night. And happy to be with you next week if our day is not available. Thank you.
Recording